My name's DiGiulio. I'm the Director of Nationwide Lung Health Policy at the American Lung Association. With that information, you know absolutely nothing about what I do. I direct our tobacco cessation policy work, and I work on our access to care portfolio. My team and I collect the state Medicaid data, state tobacco cessation coverage data in those state Medicaid programs. We publish that as part of we're the data source for the CDC state system, and we publish that in MMWRs. We also provide technical assistance to state tobacco control programs and their partners, as well as national partners, which CTRI and C3I, we are honored to count as such. So with that, I'm going to move on. I have some brief learning objectives today. I'm hoping, again, to create maybe more confusion around billing, or just some ways to think about it in some nuanced ways, as well as ways to show value without necessarily being able to bill for some services. And so I'll get into that, but talking about different types of health plans and coverage requirements and how those barriers relate to that. I'm going to talk a little bit about, kind of the different components of the cessation intervention and recognizing that not all of them are billable. And then, again, challenges around billing for cessation and potential solutions. I'm going to start with some slides that I'm sure everybody knows, but I just like to level set to make sure we all are kind of on the same page moving forward. And so this is relatively old data, but it's the most recent data we have. It's from an MMWR that was published a number of years ago about attitudes towards quitting. And approximately 70% of smokers want to quit. This is across all demographics, whether that be age, insurance type, income. We know that most smokers want to quit. We know about half have tried to quit, about half have received advice from a provider to quit. And I think this is where we get a little bit to the troubling data, that only a third have used an evidence-based cessation intervention, and then only 1 in 10 have quit successfully. So really, there's a huge disparity between the number of individuals who want to quit smoking and the number who actually do. And so that's one of the things that we're going to talk about today. And I think a lot of the work that everybody on this call does is to try to make those numbers match up a little bit more. So when we talk about evidence-based treatment, we're looking at that clinical practice guideline from 2008, which we know is old, but is the best we have right now. This information has been reiterated by the United States, my gosh, my brain is not right, USPSTF, United States Preventive Services Task Force, as well as the Surgeon General's report on smoking cessation. So we know that there are the 7 FDA-approved medications. The caveats to that are 3 of them are over the counter. So in order to get those with no cost sharing, you need a prescription from your insurance. So there could be some issues there. And then we also know that the inhaler is no longer being manufactured. So there are some issues there. That being said, it's still considered an FDA-approved cessation treatment. The manufacturing has not changed FDA's categorization of it. And then we know that there are 3 types of counseling. Individual counseling, which is frequently billed as 99406 or 99407, depending on the length of the intervention. Group counseling, which is frequently covered as a class, but potentially may be part of a wellness program and not part of a traditional fee-for-service billing model. And then phone counseling, or the quit line, and that gets even more tricky to bill, because we know that anyone can call 1-800-QUIT-NOW and get quit line and phone counseling services with no cost sharing. So that's where we're at. The other piece that I wanted to talk about a little bit is barriers to accessing care. And these, I think, tend to be more, stand out a little bit more in the Medicaid program, but happen for everyone and can impact everybody. So this includes cost sharing. So anything, any copay, deductible, anything like that. Prior authorizations, duration limits, yearly or even lifetime limits. And unfortunately, we still see a handful of lifetime limits in some Medicaid managed care plans, dollar limits. So, there's only, maybe we'll provide, the insurance plan will pay $200 towards a quit attempt per year. Stepped care therapy. So that is, needing to, try and fail on one medication before trying the medication you want. And we know that it takes, on average about 8 quit attempts for somebody to quit successfully. So We don't want to create any additional barriers. And sometimes a person may have tried a medication the year before and failed on it. So that might not be the best course of treatment. And then the last one, and it might have a lot of you scratching your heads, especially if you're clinicians thinking about required counseling. And so we know that the best way for an individual to quit smoking is the combination of medications and counseling. That's the silver bullet we have. That being said, especially when we look at, again, lower income populations and Medicaid specifically, we don't want to make counseling a barrier for people to access treatment. Whether that be people don't have enough minutes on their phone to access phone counseling, it's hard to get transportation or childcare to attend in-person group or individual counseling, or time off of work for those things. So we want to make sure that everybody can have a quit attempt, regardless of if they have time and resources for some of those extra, so some of the extra pieces. So now I'm going to kind of dive into the meat of the topic and the billing for cessation. And so I like to think of billing as layers of an onion, because when we talk about billing, we want to make sure that patients utilize cessation treatment and evidence-based cessation treatment. We want qualified providers to furnish that cessation treatment, and we want them to get reimbursed for that. And billing issues arise when that doesn't happen. And so frequently, is it actually an issue of the right CPT code with the right diagnostic code, or is it an issue with prior authorization, or is it an issue with payment type? So today we're going to talk a little bit about why providers aren't getting reimbursed and what some of the causes of that might be, and then some other options around quality measures to kind of show value of the work of cessation, even if it's not getting that fee-for-service reimbursement. So first and foremost, before we even get started and to kind of start to understand the landscape, I think we need to take a step back and look at the types of insurance that we have in the United States. These are listed in alphabetical order, so there's not really a rhyme or reason, but I'll go through them quickly. There are a lot of people in the United States and they get health insurance in a lot of different ways. And for the sake of ease of conversation, I'm going to refer to Medicaid and TRICARE and VA as insurance, even though that they technically don't qualify with that definition. So there's approximately 80 million people on Medicaid in the United States. That number is going to drop a little bit in the next. It's probably a little bit less than that right now. That was kind of in the height of the pandemic, but that's generally around where we are. Really, the state makes a lot of the actions and makes a lot of the decisions around this. There are two main types of Medicaid, but there's a lot more nuance than that. But we've got expansion, and then we've got standard Medicaid, which is the non-expansion. So those would be people who would have qualified for Medicaid pre-expansion. Expansion is 138% of the federal poverty level. And I don't know what that is in dollars right now, but I think it's around $35,000 a year for a family of three. So it's a pretty low threshold, and that's in the more expansive states. There are 10 states that still have not expanded. So that's where we're at. When we look at Medicare, we're looking at about 60 million people. Again, that number is going to fluctuate a little bit. Again, Medicare is going to be for people who are 65 and older, as well as people who are disabled. It's really very difficult to prove SSDI or Social Security disability insurance. That is the level of standard that you have to get to be able to get disability coverage via Medicare. For Medicare, there is one decision maker. There's a national coverage determination that happens, and we'll get into what that is in terms of cessation in a little bit. The caveats that we have to think about is, while some people get Medicare through parts A, B, and D, D being drug coverage, A and B being inpatient and outpatient care, there are also Medicare Advantage plans, which are kind of a private alternative for Medicare. So there's some variation in coverage there. Private insurance is the biggest bucket of insurance. You have mainly employer sponsored, but some people get plans on the individual market. Some plans are regulated by the states. Some plans are regulated by the federal government. That's depending on who takes the financial risk of each of those plans. And then on top of that, there's a whole crop of plans that are unregulated. There's a whole bunch of different types, whether those be Farm Bureau plans, healthcare sharing ministries, short-term limited duration plans, association health plans, but those kind of are all fall under a big unregulated umbrella that don't have to follow any sort of requirements, and have a lot of exclusions and kind of get us back to the pre-ACA wild west of healthcare. In addition to all of those plans, there are benefits via TRICARE for active military and their families, and then the Veterans Administration for veterans. So that's kind of generally what we're looking at when we look at the category of who has coverage. What is obviously missing here is people who are uninsured, which we still have a lot of. I briefly mentioned the Medicaid unwinding a few minutes ago, and so that is obviously adding to those uninsured individuals. I'm going to go through kind of some just basic coverage requirements for each of these, which I think will start to identify why people may have problems with billing. And this is going to be where we start, and this is very easy. So standard Medicaid, so those are going to be people who would have qualified for Medicaid before the Affordable Care Act. In some was passed and expansion happened. In some states, I'm looking at Mara, who's in Wisconsin. Wisconsin is a non-expansion state, so anyone in Wisconsin has standard Medicaid. Alabama is also a non-expansion state, as is Tennessee, but all states have kind of this both population. Well, all states have both populations, not all states cover both populations. But Section 2502 of the Affordable Care Act essentially removed cessation medications from the exclusion list. Before ACA, tobacco cessation was treated as a cosmetic drug under Medicaid and not necessarily required to be covered. So cessation is required to be covered now, but there's a couple of caveats. First and foremost, it does not address, this provision of the Affordable Care Act does not address counseling. So there's no coverage requirement at the federal level for standard Medicaid programs to cover cessation counseling. That being said, there are 39 states who cover individual counseling for at least some or all of the population, and there are 21 states that cover group counseling for at least some or all of their standard Medicaid populations. The sum comes when one managed care plan covers it and the others don't, or vice versa. We also know that there's still some variation in states covering FDA-approved cessation medications, so that can be problematic, and states are still allowed to charge copays to this standard Medicaid population for these medications and treatments. There are some different coverage requirements for pregnant people. So the 2010 ACA requirement, that's the year that went into effect. It was very early on. It's Section 4107. And it says all pregnant women on Medicaid must have access to all cessation treatment. So all 7 medications and 3 forms of counseling without cost sharing. The Lung Association uses gender neutral language like pregnant people. However, the law says pregnant women. So that's why there's a dichotomy on the slides. It's not a typo. Moving into private insurance, the ACA did a number of things to protect people with private insurance. And this is in that regulated market. So this is most employer-sponsored plans, as well as individuals and people on the individual market. This is not those junk plans that I mentioned a few minutes ago. So the couple of things that those plans are supposed to do. So you have to be able to get insurance that's guaranteed issue. Children are allowed to stay in their parents' health plan up to age 26, and you can only vary premiums by a few things, 4 to be exact. Age, so you can only charge the oldest person who's 64 3 times as much as the youngest person who's going to be 27. You can change the insurance rate based on the number of people in the family. You can change it based on the geographic size. And then unfortunately, you can change it based on tobacco use. So if an individual uses tobacco, you can charge not only that individual, but their entire family 50% more than you would have otherwise charged them. States can add additional protections, including eliminating or reducing that tobacco use status. The other thing that private insurance was required to do was it was required to cover the essential health benefits. It's a list of 10 services which are written out here. So you can see these are kind of what we think of as healthcare. It's prescription drugs, it's lab services, it's emergency services, hospitalization. I'm not going to read them all off because you guys are all very smart people and could read yourselves. And Mara's going to send out a PDF of my slides afterwards. So if you want to go back and check, you can do that. But this is kind of, again, essential health benefit, what it says. It's kind of the common services. The one I'd like to draw your attention to is the second to last on my slide, which is the preventive and wellness services in chronic disease. And so the way this has been defined in the subsequent regulations is anything receiving an A or a B grade from the United States Preventative Services Task Force, or USPSTF, which does trip me up, and it did a few minutes ago, I'm sure it will again, has to be covered by health plans that are required to cover the essential health benefits with no cost sharing. And so that is very clearly written into the law. Tobacco cessation gets an A grade from the United States Preventative Services Task Force. It has gotten an A grade for well over a decade in some form or another. Periodically, it gets updated to add any evidence, but we're talking about all 7 medications and all 3 forms of counseling. There are a number of plans, again, who have to cover this preventive services requirement as either part of the essential health plans or kind of just written in separately. So again, as I mentioned, almost all private plans, including any plan sold in the exchange, small group plans, individual plans, Medicaid expansion plans, and then some association health plans. There's also a whole set of plans that don't have to cover this and have either no coverage requirement or have different coverage requirements. And so standard Medicaid plans have different coverage requirements, as do Medicare plans. And then all the other ones don't have to cover anything. So that's where we're at. As I mentioned, tobacco cessation receives an A grade from the United States Preventative Services Task Force. I will say, if you've ever read the USPSTF language, it is clinical guidelines, clinical guidance to clinicians on how to treat patients who use tobacco. It is not coverage guidelines, it's not insurance language. So over a decade ago now, over a decade ago, the Departments of Labor, Treasury, and Health and Human Services. And those are the 3 federal agencies that regulate insurance coverage, whether that be Medicaid, employer-sponsored, or provide some of the tax benefits associated with insurance coverage, issued a frequently asked questions, or an FAQ. And this FAQ is a way to translate that clinical guidelines into what insurance coverage should be. So that's the best way that I can describe it, is really that translation. And it says that to be in compliance, you should be doing at least this. So for each quit attempt, you should provide at least 4 sessions of individual, group, and phone counseling, and at least 90 days of an FDA-approved smoking cessation medication when prescribed. And every patient should have at least 2 quit attempts per year, and a quit attempt should have no cost sharing and no prior authorization associated with it. So it is significantly better than we were in a pre-ACA world, but I think we can all see this and see some room for improvement now. But I think, if you're going to do that 9th counseling session, you might have an issue from a billing. You might look like a billing issue when it's really more of a coverage issue. And so that's kind of, I think, one of the reasons that I wanted to talk through a lot of this with everyone today. So when we think of a cessation intervention, there are 3 elements of it. And Mara had this in her initial slide. Screening for, billing for screening and treatment of tobacco use. And so the first piece of this is screening for tobacco use. And we know kind of a cessation intervention is going to be screening and then counseling and medication. And so those are the elements we're looking at. Screening for tobacco use is not in and of itself a billable service. There are plenty of times, whether that be with EHR metrics in order to get incentive payments or to not get dinged, that you need to record the number of patients who report using tobacco or not. But there's not an individual unique billing code for screening for tobacco use, but you're not going to be able to do counseling or medication if you don't screen. So that's another issue there. And then we have counseling, which again can either be done by the provider that does the screening, or it can be referred out to either a group session, TTS, or to a quit line. And then the medication. And that, again, is going to come at the point of sale at the pharmacy, where that either gets covered or doesn't get covered. And I think the reason that it's important that we talk about medication here, even though, a provider isn't necessarily going to get the reimbursement for that medication, is if a patient abandons their prescription at the pharmacy, they're not getting treated, and that creates a problem. That medication utilization is really important. The other thing I think that's really important to keep in mind when we talk about billing is the reimbursement models. And so 10 plus years ago, when ACA and kind of different forms of healthcare were discussed, there's a huge push to move from fee for service to a bundled payment system. And so again, I'm 90% sure most of you know this, but if you don't, apologies. If you do, I'm sorry if I'm talking, telling you stuff you already know. But fee for service is, again, when a provider is reimbursed for each individual service or test that they do. Again, this incentivizes the number of procedures being done. Historically, this has been talked about as, providing or paying physicians and providers to treat sick, whereas bundled payments are paid to keep people healthy. There's always going to be some sort of fee for service in our healthcare system because we're going to want to incentivize some treatments. But bundled payments are when the health system or the provider gets one payment for one episode of care. So that episode of care could be pregnancy and birth, regardless of how complicated it is. That one episode of care could be taking care of a patient after a heart attack. It could be for, kind of whatever it is. There are some bundle payments that even go a step further and say, we're going to pay X number of dollars for X number of patients. Those we're not seeing quite as much, but that's kind of the overall goal of bundled payments. So, and again, when you combine these with quality measures, which I'm going to talk about in a few minutes, the idea is to incentivize providers to keep patients healthy. There's a lot of debate and a lot of discussion over whether this is actually the way this is actually happening, but that's kind of the overall structure of it. But if you work in a health system that does fee for service versus bundled payments, or the opposite, you're going to have a very different lens to look at reimbursement through. And so it's really important to understand how your health system does payments to know if you're billing correctly or not and where your billing issues come in. So we're going to go through the different, I'm going to go through the different types of, or some of the different types of health insurance, and talk about kind of who makes the decisions and where the decisions are made and kind of what some things need to be considered for them. So in Medicaid, the state is the decision maker. There's a federal floor of coverage, which we talked about being, 7 medications, but states can require additional coverage, and a number of them do. Kentucky is one of them. Illinois does. Ohio, there are plenty that I can't think of too. So there's really, kind of a whole, Missouri is actually one of them too. There's a whole host of states that do this. And I will say this is not necessarily a red state, blue state thing, as you just heard me rattle off a number of states. The structure of the Medicaid program is important. Is it an expansion state? We've seen, based on kind of just doing data collection, expansion states, for the most part, they can separate out their expansion population from their standard population. Few states are actually doing that. Most states are offering the same benefit to both. So that could potentially change what your coverage is. Additionally, does the state have a lot of managed care, or is there fee for service? So is there kind of a, are there a bunch of different plans that individual could be on, or is there just one? And what does that look like? We also know that state Medicaid programs are starting to have to report in the behavioral health core set that measure NQF 0027, which is medical assistance with smoking and tobacco use cessation. So this is the number of patients that get cessation. It's every 2 years. So it's not the best number, but it's not the worst, and it's more than we have historically had. Moving on to private insurance. And again, this is going to be the vast majority of people in this country have private insurance. Most get employer-sponsored coverage, either from their own employer or their spouse's or parents' employer. Again, you could have a fully insured plan versus a self-insured plan. A fully insured plan is what we typically think of as insurance. You pay a premium, your employer may pay part of it, you may pay part of it, and then the insurance company pays claims after deductible and copay and co-insurance and all of that fun stuff. A self-insured plan to the patient probably looks the same as a fully insured plan. You're going to have an insurance card that's going to have the name of an insurer on it. It might say, Cigna, it might say Blue Cross, and you might even pay what is considered quote unquote premium. However, that is going to go to your employer. The employer is taking on all the financial risks and is actually going to be the entity that pays the claims. The other thing is if you've got a non-compliant plan. So maybe you ended up in a short-term, a patient ended up in a short-term limited duration plan. I'm not going to talk about the advertising for those, but if you listen to some of the same podcasts I do, you might get some advertisements for them. They don't sound bad, but that is not how I would describe them. So to just recognize like what type of plan you're dealing with and like where the decision maker is for that. And again, you could be in a state that requires additional coverage. Ohio, for example, requires their state employee health plan to cover a comprehensive benefit identical to the Medicaid plan. Kentucky also has a requirement for all state insured plans. One thing I will know, and shoot, this slide is still messed up. I am so sorry. State laws are not applicable to self-insured plans. They are applicable to fully insured plans. Mara, I will fix these and then send you a new PDF to send out. So, because the self-insured plan is going to be regulated by ERISA at the federal level, and so that not the state level. The insurance commissioner does a lot of regulation in this and has authority to issue bulletins and other regulations. Medicare, again, there's a national coverage determination. These coverage determinations are for almost all treatments and services. I'm sure, there was a lot of talk about, a number of the Alzheimer's drugs with some of the national coverage determinations. A lot of you just recognizing kind of the intersection between lung cancer and tobacco use may be aware of, some of the lung cancer, the national coverage determinations that have happened recently. So it's a national level determination. Medicare Advantage plans, again, those are the plans that mimic private insurance, are able to be more generous than kind of that standard A, B, and D. Medicare, from a counseling perspective, covers 99406 and 99407 8 times a year. So 4 sessions twice a year, but it's really 8 times. You don't have to have them in the different quarters, whatever. The caveat I will say to this, and this is really frustrating and confusing, is especially if you're at the end of the year, you don't necessarily know how many of those 8 sessions a patient has used. So if you have a frequent flyer patient that goes to a lot of providers and has a lot of health conditions, which is not unfrequent in Medicare, considering what the population is, they may have been counseled 8 times before you see them, and you might get a claim rejected, not because you did anything wrong from a billing perspective, but because they've already met that annual limit of 8 sessions per year. So, and you could have 99406 or 99407, but it's 8 total sessions a year. So you couldn't do 8 of 99406 and then 8 of 99407, but you can have whatever combination of the 2 you want. And 99407, for those who don't know, is greater than 10 minutes. 99406 is going to be, I think, 3 to 10 minutes of a counseling session. The other piece is that Medicare's decision memo on counseling clearly states that only Medicare recognized practitioners and qualified physicians can furnish cessation counseling. Unfortunately, this does exclude tobacco treatment specialists. That being said, tobacco treatment specialists can bill incident to one of those providers to be able to get some reimbursement there. And then lastly, prescription drugs are the only medications that are covered in Medicare. It's not specific to cessation, it's across the board. So the gum patch and lozenge are not covered for Medicare patients, even with a prescription. just checking the time. I think I've got a little bit more, and I promise, Mara, I'll go quick so we can do some questions. So just
You're
quickly,
fine. Take your time.
okay. Moving to quality measures, again, what are quality measures? And so again, I like to think of this as a way that providers can show value other than just getting dollar reimbursement. So really about kind of driving, the whole goal of this is to improve healthcare coverage, spend dollars more wisely, and improve outcomes. We can have a long discussion whether or not that is happening or not, but we do know quality measures exist and that they are being utilized. There are different types of measures. So again, some of them, and so to think about, when we think about cessation and where providers fit in, to think about what measures exist for the health system that you're in or the state that you're in, or kind of where you work and how you bill. Are there outcome measures? Some of them are going to be process measures. Some of them can be composite measures. And so tobacco fits into all of these, and there are different measures, and I've got a slide later on that'll talk about that. And then there's different reporting levels as well. So again, some of them, sometimes the health plan reports on them, sometimes it's the health facility, the hospital system, or sometimes it's the individual clinician. So kind of figuring out what that is and what makes most sense, again, for you and your system and what your specific situation is. There is a rigorous development process for quality measures. You can see this chart that I stole from the CMS website. There's a lot of arrows that go back and forth. It's a very circular process. There is a sponsoring organization or a steward of these measures, and they have to maintain and update the measure and make sure it works. Part of the testing is making sure that you can actually get the data you need, which has been a challenge a lot of the time for cessation measures, but we are moving in the right direction, and there are a number of measures that we currently have. Again, the ways they can directly impact patient care. 0227 is again at the system level of if a health system is screening and providing treatment for tobacco use every 2 years for patients. That is used in the marketplace quality system. The 0228, which is that same measure, but on the individual provider level, is used on the merit-based incentives program, or MIPS, which you may have heard of or may participate in, because I know there's a number of providers on this call. And then lastly, that 0228 is also used in the physician compare tool. So ways that patients can try to decide what provider has better outcomes. So now I'm going to talk a little bit about specifically measures specific to cessation. I just threw a couple quotes from the US Surgeon General's report on smoking cessation. That was from 2020. And again, I think a lot of these will help encourage people and can help encourage people to not only, providers providing cessation, but also people encouraged to quit. So there's a number of measures, and I'm not going to go through them. And there are, these are specific to cessation. Again, some of them are at the clinician level, some of them at the health plan level, and some of them are at the facility level. Some of the TOB measures have been used as part of the psychiatric inpatient screening program, or psychiatric inpatient prospective payment system. Excuse me, I misspoke. But kind of a way to pay Medicare providers when they see patients in behavioral health settings. Additionally, there are a number of measures that are composite measures where tobacco is part of it. So there's an anesthesiology smoking cessation, smoking abstinence, part of the diabetes composite number, which is another really great way to kind of get at this from a different angle, depending on the goals and priorities of the health system that you work in and kind of what you do. So it doesn't necessarily have to be a cessation or tobacco thing that you're specifically working on. Again, these can be used for provider payment. We talked about that a little bit. Accreditation, EHR incentive payments, a number of different things. And again, I think, federal agencies can require these, but organizations can also use these to show kind of how they're doing. sometimes there's a number of times where there's a menu of options and the organization needs to pick which quality measure they're using. So if you have the ability to influence it and encourage one to be a cessation measure, that could be really great. And then lastly, I know Mara shared our billing guide before, but we also made an addendum to that that's specific to behavioral health. So that could be helpful depending on where you work. We also have a matrix that looks at a number of different quality measures that I mentioned, and to kind of see where one may or may not fit into your work. And then lastly, we have our state database on tobacco cessation coverage and state Medicaid programs. This is generally a public health data set, so I would not use it to make clinical coverage decisions, but it can be a good place to start.